Welcome to today's lecture, and we're going to talk about major depressive disorder. Major depressive disorder, also known as clinical depression, is not just a symptom of feeling sad, but it's a disease. And it's a disease that affects the mood, that is, the emotions of the patient. It affects the cognition, that is, the thought patterns of the individual, and the behavioral patterns. It consists of a number of symptoms which include a low or depressed mood, anhedonia, that is the inability to derive pleasure from activities that previously gave the individual pleasure, feeling guilt or worthless, appetite changes, either obesity or undernutrition. Some people rather under stressful situation eat a lot, meanwhile others lack the appetite. There's also lack of energy, poor concentration, sleep disturbances. The patient rather has difficulty in going to sleep and does not finally sleep for a long period of time. The most devastating symptom is suicidal tendencies, and there's also psychomotor retardation. Now, the epidemiology. The World Health Organization 2020 reports that 264 million people worldwide are affected by clinical depression, with a female predominance of 8.7% of females and 5.3% of males, all within the age range of 18 to 25 years, probably due to the high rate of drug and sexual abuse within that age range. 700,000 suicides per year were also reported. World Health Organization 2017 reports 322 million people with clinical depression and 9% of them being African. The causes or etiologies of clinical depression are many and grouped under several headings. First, genetics, that is, clinical depression runs in families. So if you have a family member who has clinical depression, it increases your likelihood of having clinical depression. Environmental factors also, such as drugs abuse, alcohol abuse, conditions that are excessively stressful, sexual abuse, sad news like the news of a loved one's death, nutrition like low omega 3 fatty foods, which is usually gotten from fish and eggs. Climate change usually occurs in north and south poles in cold conditions. There are also biological factors such as physical illnesses like hypothyroidism, hormonal changes which occur in menopause and pregnancy, for example, and most importantly, brain chemical changes, which involves the three important neurotransmitters: serotonin, dopamine, and noradrenaline. Serotonin plays a very important role in appraising information that contain emotion. Increased levels of serotonin have shown elevated mood, feeling happy, and also tryptophan, which is the amino acid from which serotonin is derived, being low causes a low serotonin. Dopamine plays a role in motivation and reward, and low levels of dopamine cause anhedonia and low motivation, and also feeling helpless. Long or serious or severe short-term stress, trauma, and pain cause depletion in dopamine. Noradrenaline plays a role in cognition, motivation, and concentration, and low levels lead to attention deficits. Other neurotransmitters that are involved in the pathogenesis of clinical depression are gamma aminobutyric acid, also known as GABA. It causes clinical depression when its levels are low, or the levels of its receptor GABA A are also low. It's important to note that gamma aminobutyric acid is an inhibitory neurotransmitter. Glycine is another inhibitory neurotransmitter involved in the pathogenesis of clinical depression. Research have shown that supplementation with glycine improved clinical depression state. Glutamate is an excitatory neurotransmitter, with some research show an increased level causing depression, meanwhile others show a decreased level rather being the cause of clinical depression. Antagonists to NMDA receptors, which are the receptors of glutamate, have antidepressant effects. Now about the diagnosis of clinical depression. It's a clinical diagnosis and based first on the symptoms, which are 9 in number, which as previously mentioned involves low mood, anhedonia, low energy, feeling guilt, poor concentration, appetite changes, either obesity or undernutrition, psychomotor retardation, sleep disturbances, and suicidal tendencies. Another very important aspect in making the diagnosis is the past history, of which we get information about the medical history, such as histories of hypothyroidism, family history, alcohol abuse history, drugs history, and other issues such as sexual abuse. But clinical investigations are also important and are mainly laboratory and are mainly to rule out any metabolic causes of the symptoms. There is a guide that helps us make the definitive diagnosis of clinical depression. It's brought to us by the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. It gives us a list of 5 criteria that help us make the definitive diagnosis of clinical depression. The first thing on that list is you need to have 5 or more of the 9 key symptoms of clinical depression, any 5 of them. Secondly, the symptoms should bring about clinically significant distress in the patient, and also it should interfere in the social life of the patient and even the occupation. Thirdly, the symptoms should not be attributed to drugs or side effects of drugs or any medical condition. Fourth, it's not better explained by any other disorder like schizoaffective disorders. And lastly, there should be no previous manic or hypomanic conditions. Subtypes of clinical depression include seasonal affective disorders (SAD), which mainly occurs in the north and south poles, and it occurs commonly in the winter season and also during periods of longer nights and shorter days. The symptoms usually are that of sad mood and low energy. Another subtype of clinical depression is psychotic depression, which is simply clinical depression associated with delusions and hallucination. Another very important subtype of clinical depression is postpartum depression, which occurs after 12 weeks within 12 weeks following delivery, that is the postpartum period. And it's important to distinguish this from baby blues. Baby blues last about 2 weeks, meanwhile postpartum depression lasts longer. Another type of clinical depression is melancholic depression, which is characterized by a number of symptoms that pertain to a melancholic state, such as loss of pleasure from many or all activities, loss of reactivity to positive news, feeling of despair, sleep disturbances, weight loss, feeling guilt, and these symptoms commonly occur in the morning. Another type of clinical depression is catatonic depression, which is a clinical depression associated with abnormal movements of the body and behavior and withdrawal. Another type is bipolar depression, which alternates between extremely low moods and normal mood. There's also a persistent depressive disorder in which there is low mood or depressed state for more than 2 years without even up to 2 months of normal state. How to then treat or manage clinical depression? There are a variety of ways, and first we'll start looking at the pharmacological management. The number of or the different types of medications used here have shown to have equal potency but vary mainly in their side effects. So let's start with serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, SSRIs. Now, serotonin is a neurotransmitter secreted from the presynaptic vesicles into the synaptic cleft onto the receptors, and then it has reuptake channels. So, selective serotonin reuptake inhibitors inhibit or block the channels for the reuptake of serotonin, allowing the accumulation of serotonin in the synaptic cleft. Examples of these drugs are citalopram, fluoxetine, sertraline. Another type of drug used for depression are serotonin noradrenaline reuptake inhibitors. These inhibitors have both the ability to block the reuptake of serotonin and also the ability to block the reuptake of adrenaline and function to accumulate serotonin and adrenaline in the synaptic cleft. Examples include desvenlafaxine and duloxetine. Another example of antidepressants is serotonin modulators, which increase the sensitivity of serotonin receptors. Examples include trazodone. Another class of antidepressants is tricyclic antidepressants. They also block serotonin and noradrenaline reuptake, but they have different structures and also different side effects as the previously mentioned antidepressants. Examples include imipramine and trimipramine, and of course they have some very severe side effects. Another class of antidepressants is monoamine oxidase inhibitors, which inhibit monoamine oxidase. Monoamine oxidase is an enzyme that normally reduces the amount of serotonin, noradrenaline, and dopamine in the brain. So inhibiting this enzyme causes the brain to accumulate sufficient amounts of serotonin, noradrenaline, and dopamine, which are good to improve the state of clinical depression. Examples of the medications here include isocarboxazid. Now, there are also atypical antidepressants which can be used alone as monotherapy or in conjunction with other antidepressants if the side effects of those antidepressants are severe. Examples of such medication include mirtazapine and bupropion. Other management methods include psychotherapy, which involve cognitive behavioral therapy, which helps patients identify and modify maladaptive thinking and behavioral patterns. Interpersonal psychotherapy, which focuses on current interpersonal difficulties like grief and disputes. Psychodynamic psychotherapy, which brings out psychological roots of emotional suffering. Behavioral activation therapy, which uses behaviors to influence emotional states, and creative arts therapy, which uses art and music, etc., to improve psychological and social well-being. There's also electroconvulsive therapy, which is used to impact the functioning and effects of neurotransmitters in the brain. The most potent treatment method, but is used only in severe cases that has not responded to other treatments and involves brief electrical stimulation of the brain. Another management method is transcranial magnetic stimulation. Transcranial magnetic stimulation uses magnetic pulses to stimulate nerve cells in the brain that are involved in regulation of mood. It's used for the treatment of refractory or resistant depression. Some other specific types of medication can be used. For example, esketamine is a nasal spray that is used in conjunction with an oral antidepressant and used in the treatment of treatment resistant depression. Another treatment modality is the use of herbal medicines. Herbal medicines that have been shown to improve clinical depression are St. John's wort, kava, valerian, acai, and S-adenosyl L-methionine, also abbreviated SAM. There are other methods of treatment of clinical depression, such as lifestyle changes to avoid taking alcohol or recreational drugs, for example, acupuncture, and vagus nerve stimulation.